Welcome, and thank you for joining us for this presentation, A Patient-Centered Approach to Severe Asthma Management, Embracing Diversity and Improving Outcomes with Emerging Therapies. This activity is based on a satellite symposium from the 2017 Patient-Centered Medical Home Congress. The faculty members for this activity are Michael J. Adanazio and Michael J. Cawley. Participants are reminded to review the learning objectives and faculty disclosures available on the accompanying webpage. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals. This activity is jointly provided by the North American Center for Continuing Medical Education and the National Committee for Quality Assurance. Following the conclusion of this activity, participants should be able to distinguish between the multiple clinical presentations of asthma in terms of symptomology, diagnostic criteria, and comorbid conditions in order to reach an informed, accurate diagnosis, outline the efficacy, safety, and mechanisms of action of new and emerging biologics for the targeted treatment of severe asthma, design and implement severe asthma treatment plans that incorporate pharmacotherapy tailored to individual phenotypes and endotypes, and employ PCMH standards, guidelines, and measures to provide coordinated, individualized asthma care and improve patient adherence and outcomes.
Okay, let's go on forward, ladies and gentlemen, start talking about asthma. First of all, I think we're very, very familiar with the disease process, and what I want to talk about is some of the description of asthma and some of the diagnosis and diagnostic criteria associated with it. As we're aware, we know that it has variable symptoms, some shortness of breath, wheezing, cough, and chest tightness. And the patients, of course, can meet some of those criteria or all of them. But one of the biggest issues is airflow limitations. I'm going to talk about spirometry, forced expiratory volume, and some parameters that are very important in assessing patients and diagnosing them with asthma. And we know that symptoms can be variable. We know that they can resolve spontaneously. We also know that they experience flare-ups or exacerbations. And finally, I think we're very familiar with the triggering mechanisms. We talk about some colds or some type of antigen that could stimulate that reactive airway component, and I'm going to talk about those. We could have changes in weather, we could have various irritants as cigarette smoke and so forth. And I'm going to get into that in just a little while. So let's get into it a little bit deeper in regards to the diagnostic criteria for asthma. On the left-hand side, I talk about the diagnostic features that I just mentioned. But on the right-hand side, I talk about some of those other criteria as we mentioned before. Those symptoms and the triggering, various things can trigger that disease process. And often it occurs in patients with viral infections also, that a lot of people aren't aware of. They most think of it's a bacterial, but it could be viral also. But I want to spend a decent amount of time on here. And it's a very busy slide, but there's some specific things I want to bring up. On the left-hand side, we talk about the diagnostic features. And the second line you have down there is the positive bronchodilator reversibility. What does that mean? What happens is when we give a patient a bronchodilator, before we do the bronchodilator, we do what's called flow volume loop testing or spirometry testing. And then we give a patient a bronchodilator, and then we want to see a change in their forced expiratory volume in 1 second. When we do spirometry on patients, we want to, if they're already on a bronchodilator, we want to hold it for as long as possible because we do not want that pulmonary function to be impacted by the drug therapy that the patient is on. So the SABA is the short-acting and the LABA is the long-acting, and that's how long we want to kind of hold those drugs before we do the spirometry. On the same line, on the right-hand side, we talk about the FEV1, and I want to bring that up. That's a very important point. As a general rule, what you do is when a patient has, when we're going to do spirometry in a patient, and we do a baseline spirometry testing, then we would give them the bronchodilator, 200 or 400 micrograms of albuterol, or 2.5 milligrams of nebulized albuterol. And after about 10 or 15 minutes, then we would repeat the spirometry test. And if we see an FEV1 that increases by about 12% and a 200 ml increase from baseline, that's a reactive airway component. And you're relatively talking about a patient who has asthma. Now, a lot of the things I'm going to be talking about today are from the GISA guidelines. I think you're familiar with the Global Initiative for Asthma. They've come out in 2017. They're the new guidelines. And, of course, there's other guidelines out there, the EPR guidelines from 2007. So there's different ones to go by. And there's not one right criteria, one right guideline. But why I wanted to bring the GISA guidelines are specifically because they're the most updated. They also talk about peak flows. I'm not going to get into that much because that's more of a rudimentary test. It doesn't really give you the specifics of pulmonary function. But also there's on the bottom left-hand side, we also have exercise challenge and a bronchial challenge test that also can be done to assess the patient specifically who has a reactive airway component or asthma. So technically, from a simplistic standpoint, I wanted to talk about a diagnostic flow chart. And as you could see in the very top, you talk about a patient who has their symptoms, their cough, their shortness of breath, their wheezing. And then from there, we want to have a patient's history. So we want to get a detailed family history. We want to know if a patient has a family history of asthma. And also, do they have any history of any type of allergenic component, eczema, something like that, because that may be a sign that the patient may have a reactive airway component. And then from there, we do that spirometry testing. We do the pre and post bronchodilator test, and we want to see that FEV1 increase by 12% and 200 mLs. And then from there, if that's all true, then we have a patient that we could treat for asthma. So our patients, and a lot of us that we deal with on a daily basis because of their asthma, they have multiple comorbidities, and I just listed some of them that are there. We all know that obesity is a major issue, especially in the Western world, the United States. And if we talk about that, the mainstay of treatment for these patients who have asthma are inhaled corticosteroids and also weight loss. So the evidence B, which means it's not the most optimum data, but it's the second best data that we have in regards to treating these patients who are asthma and obese. GERD, patients who have this reflux disease, we want to know that as we have patients with actual GERD, remember that stomach acid that can reflux can actually irritate the airways and actually cause a bronchospasm to occur. So if you treat the GERD a lot of times, the asthma symptoms will not occur. So it's very important to control that disease process. We also have epinephrine. We know that for an auto-injector for patients with food allergies, and also intranasal corticosteroids for allergic rhinitis. They're the treatment of choice, but they're not very effective in regards to the rhinosinusitis. So again, depending upon the symptomatology of the patient. And then vitamin D deficiency. In the past 5 years, there's been a lot more data coming out on the role of vitamin D. And vitamin D seems to have a role that we don't completely pinpoint it yet, but we understand it has some type of effect on decreasing asthma exacerbations, and we need more data out there to definitively determine that. So what I wanted to do here, ladies and gentlemen, I'm not going to spend a lot of time on this. It's a very busy slide, but this is kind of a stepwise approach to control symptoms. Again, this is the global initiative for asthma. On the very top, you have the review the patient's response, you have the assess the patient, and then you adjust the treatment. On the top, you have the various steps, step 1, 2, 3, 4, and 5, and as you can see, it ramps up. So that's relatively telling us we're ramping up our drug therapy. We're getting more aggressive. On the very bottom of the table, you have the reliever medications, the short-acting beta agonists the patients are always going to be on during their disease. But on the very top, when we talk about step 2, we have low-dose inhaled corticosteroids, then we step it up to low-dose in ICS and ALABA. And as we keep going to step 5, you can see step 5 here that I have tiotropium. And everybody's familiar with tiotropium, right? It's an anticholinergic that is used for COPD, but it has a role in asthma. There's a lot more data that has shown that a tiotropium as an anticholinergic is very effective in patients with asthma. But I'm going to spend a lot of time on the biologic therapies, the anti-IgE and the anti-ILS interleukin therapies. We're going to spend time on those, and I'm going to explain those in detail because the landscape is changing very, very quickly when we're talking about this drug therapy. Now, forgive my pictorial here. I'm not the best artist. My daughter tried to help me a little bit with this, so help me. I'm going to walk you through this pictorial to show you what this means. So if we have the top, we have an allergen, whatever it may be. It could be cold air, or it could be smoke, whatever it happens. And this allergen stimulates what we call the naive T cell. And this actually then stimulates what we call the Th2 activation or Th2 cell. That is so key to this whole mechanism. I want you to focus in on that. On the top left, we have FeNO, which is nitric oxide, a fraction excretion of nitric oxide. That's also a byproduct, and that's associated with edema and inflammation. And we're starting to learn more about that as a mechanism of causing asthmatic or reactive airway. But let's go down to that Th2 component. When we look at the Th2, what that does is it does a couple things. First of all, it stimulates what we call IL-4, or interleukin-4, and that stimulates the B cell. And then you have a production of IgE. All that green stuff that's on that slide is IgE. And all this IgE stimulates mast cells, basophils, and eosinophils. And what does that immediately do? It releases all these mediators, the red things, into the airway that causes the bronchospasm. Now, there's another thing that happens with that allergen. Besides that IL-4 and production of IgE, as you go down the slide, you have the Th2 cytokine production. It also produces all these interleukins, IL-5, IL-3, all the way up to IL-13. And what they also do is affect all those effector cells. Now, what happens is from there we have fibroblasts that are also produced. And what they do is they produce a protein called peristin. And peristin, actually what that does is it causes airway remodeling. So in asthma, as you can see, this allergen does a whole host of problems. It releases a lot of mediators, and it causes airway remodeling. So if we have a drug therapy that can modify that and improve that, that's the ultimate outcome. Now, there's two things I want to talk about, the phenotypes and the endotypes of asthma. And I just mentioned some of these. On the left, you have the inflammatory cells, which are the eosinophils. Those eosinophils that are released as that picture I just showed you. In the blood and the sputum, and I told you what those specific receptors and the results are, and I have listed there. Because a lot of the drug therapies are targeting eosinophilia, a large amount of eosinophils in the blood and the sputum. Proteins, one of the other proteins I didn't mention is the calcium-activated chloride channel regulator, and these are actually involved with the IL-5 and IL-13 response for eosinophilia. So again, that's another mechanism that's starting to become identified. And then we have the nitric oxide, as I said before, that leads to swelling and inflammation. It's also been associated with elevation of IL-13, which is one of those other mediators. Some of the endotypes, I'm not going to spend a lot of time on this, but on the left we have the allergic asthma all the way down to cross-country skiing asthma from cold air. And if you look at that, in the middle of the slide, we talk about the Th2 inflammatory process, really important. If you go down further, we talk about increased cystanol leukotriene and leukotriene C4, and some of those drug therapies, as we're familiar with, there's the montelukast and the Xylutin, and those drugs affect those mechanisms specifically. We talk about fungal IgE and IgG specifically with the bronchopulmonary mycosis, and how you would use oral corticosteroids and oral antifungals. Late asthma symptoms, again, those 5-lipoxygenase inhibitors are very key for the treatment. So again, depending upon the type of endotype these patients have, they could respond differently based upon that mechanism and which drug therapy targets that mechanism, as we just mentioned previously. So let's go back to our pictorial again, all right, just so we understand what's happening here when we talk about these biologic therapies and how they work. Remember that allergen comes along and stimulates the naive T cell, and the Th2 cells stimulated, and all of a sudden it's going to stimulate IL-4, but no, it's not. So biological therapy, which is an IL-4 antagonist, is going to block that pathway, right? So since it blocks that pathway, what does it do? It prevents the production of IgE, right? And not just that, but also some of these agents target the various other interleukins, as I just mentioned before. So since all these are blocked, the pathway can't continue. So what happens is we don't have a release of mediators, and we don't have any type of remodeling of the airway. So these are very unique mechanisms of action to try to prevent that asthma from occurring. Now look at this slide. So this is all our new and emerging drug therapy, and I think the market is going to be getting very, very busy very soon. On the left, I have the various biological agents. I have the class, what they target, IgE. Remember those eosinophils or any of the interleukins. We have the indication, and on the top three are the only three that are FDA approved at this point. So we have Mepolizumab, which has been around since 2013. We have Mepolizumab, which is 2015, and newly Rezulizumab, which is 2016. If you look at the doses, all these drugs are subcutaneous, except two. The third one, Rezulizumab, is the only one that's IV, and the very one at the bottom, Pitrahinkra, this is the only one that is a deep powder inhaler. Unfortunately, I haven't seen much future on this because a phase 2 trial was almost 6 years ago, and I don't know if the company's going to pursue this. But as you can see on the far right-hand side, we have phase 3 and phase 2 trials that are complete on a lot of these drugs. So expect the next 4 phase 3 trials that are listed there, they're probably going to be on the market soon enough. So it's going to make things much more competitive for the biologic therapy. So what are some of our treatment markers? As I said before, IgE, eosinophils, fractional excretion of nitric oxide, and peristin are various mediator markers that we're looking at. The numbers that I have listed there are usually what's associated with asthma. So if it's greater than 150 international units per ml, it's IgE, eosinophils greater than 150, and so forth. And if you look at the biological therapies, I just kind of put some of the biological therapies that have targeted these endotypes. So I think one of the things we're challenged in the literature is we're not quite sure where all these endotype markers lie. We're not sure which drugs are going to target which specific biomarkers, and also in a hospital setting. You know, if I work in a small suburban hospital, sure, we can get IgE levels, we can get eosinophils, but you're not going to be getting nitric oxide and peristin levels. So again, we don't know where that's going to go, and that's where a lot more studies are going to come to target these specific markers. So let's start talking about some of these drugs, ladies and gentlemen. The first one I want to talk about is Mepolizumab. As you were aware, drug's been around since 2003. This was a study by Lye that kind of looked at 236 studies, but they only narrowed it down to 6 because they were looking at outcomes. They looked at 2,700 patients. They looked at patients who were treated about 52 weeks and so forth. And they were looking at patients. Remember, these drugs are used for patients who are on steroids, right? So this is treatment that's added on to steroid and beta agonist and so forth. So what they did was they realized that Mepolizumab treated patients, they had lower rates of exacerbation compared to placebo. They had a steroid reduction phase with the inhaled corticosteroid doses were decreased with Mepolizumab versus placebo. And the authors felt, and based upon all that evidence out there, that this drug is indicated for step 5 or step 6 patients with severe asthma. Now, as I said before, step 5 is the GISA guidelines. That's what I was talking about. But if you look at the EPR3 guidelines in 2007, they have step 6. So it's just the same setup in regards to the patients, in regards to their difficulty of their asthma. Mepolizumab was 3 major studies they looked at. Most of these were in New England Journal and one was in Lancet. And there was a decent amount of patients. They had 135 all the way up to over 600 patients. And they looked at exacerbation rates. The Menza trial actually decreased exacerbation rate by 53% with the drug compared to placebo. Emergency room visits decreased. The DREAM trial, they actually had a reduction in exacerbations by 48% and at the other dose of 39%. And the SIRIUS trial, again, they had a corticosteroid dose reduction of 50%. You're going to see a lot of trials that are going to come out targeting dose reduction in steroids. As we know, we want to limit the amount of steroids patients are on because of the serious adverse effects associated with them. Mepolizumab, this was looking at a study of 4 different studies, a summary of all 4 of them. Again, all these studies I'm showing you are phase 3. Greater than 1,750 patients. Remember, this is the only one that's IV, right? 3 milligrams per kilogram. It's weight-based every 4 weeks that the patient would receive it. They looked at all exacerbations, and they looked at exacerbations requiring systemic steroid use. And if you look at the treatment arm, drug versus placebo, right? Mepolizumab is the drug and versus placebo. You could see the asthma exacerbation rates dropped it by 50%, in half. Extremely important. So the drug was very effective in all exacerbations, and requiring systemic corticosteroid use. Time to first asthma exacerbation. Looking at this Kaplan-Meier curve, you have on the bottom is the time to the first asthma exacerbation. And on the left, you have the probability of not experiencing asthma exacerbation. You could see that the dark line is the drug, the top one, and the bottom one is placebo. So you could see that the time was increased to the first asthma exacerbation with the active drug compared to placebo all throughout the time out to 52 weeks. Another drug I want to mention very quickly is Mepolizumab. This was the Zonda trial in New England Journal of Medicine. Again, this is a phase 3 trial. They looked at over 220 patients. But their primary endpoint was the change in oral corticosteroid use, and patients received the drug 30 milligrams sub-Q every 4 to 8 weeks. Again, the doses of Mepolizumab reduced final mean glucocorticoid dose by baseline by 75% compared to 25% with the placebo and glucocorticoid group. And they said the exacerbation rate was 55% lower with placebo and 70% lower than placebo in both the 4-week and 8-week respectively. And there was no change in FEV1. That's an important point I want to bring up because that, I think, is a big issue when it comes to these medications, at least I've looked at from the literature. Lebrikizumab, that's a mouthful, isn't it? This is LaVolta 1 and LaVolta 2 trial. This was a phase 3 trial, and both of them had about 1,000 patients, very, very similar. They looked at rate of asthma exacerbation, and they gave 2 doses, 37.5 versus 125 milligrams sub-Q once every 4 weeks. And looking at this, the 37.5 and the 125 in both trials, as you can see, they were statistically significant in both trials. They were almost identical. So it seems to me from a consistency standpoint, both of these trials proved that the drug was very effective versus placebo. Now, the drug I want to spend a little time on because it's really interesting, Depulumab. This is a Liberty Asthma Quest study. This was actually done, it's a phase 3 trial. They looked at over 1,900 patients. They want to evaluate the efficacy, safety, tolerability, and health quality of life. So patients either got 200 milligrams or 300 milligrams sub-Q every 2 weeks for 52 weeks. What did they find? Depulumab decreased the exacerbation rates by 46% overall. It's pretty significant, but 60% in the 150 eosinophil group versus 67% in the 300. What does that mean? 300 eosinophil cells per microliter is a more inflammatory response, a greater inflammatory response. So you could see that the drug actually had a better effect for the patients who had the more severe disease. The FEV1 increase in all subgroups. This is pretty impressive because I ran a spirometry clinic for about 5 years doing spirometry on patients. So when you have spirometry that's 200, 240 ml improvement in your FEV1, it's phenomenal. You could see the increased quality of life of the patients. They're able to breathe a lot easier. So I think that was a really big issue here. The injection site reaction was a little bit higher in Depulumab versus placebo. And the other study I want to mention was the Venture study. This just came out. This was 180 patients that they looked at. They looked at efficacy of the drug versus placebo and reducing the oral corticosteroid dose. Remember, I told you we want to lower that. Depulumab reduced the maintenance of oral corticosteroid by 70% versus 40% with placebo. Eosinophil counts decreased. It reduced OCS by 80% versus 43% placebo. But again, that FEV1 is pretty impressive. They had up to over 300 ml difference in the FEV1. That is the highest amount improvement in any FEV1 test that I've seen in any of the biologic therapies, and I think that's important. And the injection site reaction was a little bit higher versus placebo. Tralokinumab, I'm not going to mention much at all. It was a Stratos trial. There's not really any data on there. Clinicaltrials.gov didn't have anything out there. I was unable to find any information on it. So there is information that's going to be pending and coming out. So it's another drug that we really don't know until that data comes out to see exactly its utility. Tezepelumab, again, this is the Pathway trial. This was actually New England Journal of Medicine this past year. But this is a phase 2 trial. Of all the trials I showed you, this is the only phase 2. And there was over 400 patients. They looked at asthma exacerbation, and they looked at 3 different doses, 70 milligrams, 210, and 280 every 2 weeks for 52 weeks. They looked at exacerbation rates, and all of them were better than with placebo. The exacerbation to Tezepelumab group was lower by 61%. And again, if you look at the FEV1, it was improved, just like any of the others, but just didn't quite get it as high as the Depulumab that I showed you earlier. So ladies and gentlemen, I want to wrap this up in regards to this part of my presentation. I know I went through a lot of the medications, but it's important for us to understand that these medications are going to be something you're going to see in the very near future. I think as asthma continues to present challenges, not just both us, but also to our patients. I was just talking to Mike before. We were talking about compliance of patients and with their medications, and sometimes, we struggle as clinicians to try to tell them, and as you know, to try to improve their quality of life and improve their symptoms. But we also look at these things, we talk about the research. We're starting to better understand asthma. As the years have gone on, the literature that has come out specifically on these mediators has been really starting to help us focus drug therapy in the most severe cases. And I think that's important for us. So I think as these biological therapies continue to expand, I think we need to keep abreast of what they are. I think we need to understand their role and how effective they are in our patients. And I would ask all our people that are doing studies on this that, of course, we want to look at general outcomes. We just don't want to look at somebody's targeted markers, but we want to look at long-term outcomes for patients with asthma. So ladies and gentlemen, again, it's been an honor and privilege to be able to present to you today. And I'm going to have Mike's time to come up here, and then we're going to have some questions at the very end. So thank you so much.
Well, that was incredible. I definitely got a lot of studying to do. So we're going to shift focus a little bit now to talk about, how we attack asthma in my office. And I was asked to do this talk last week, and I spent a lot of time thinking about, what I would say and stuff. But it was relatively easy to come up with ideas because this is something that we attack in our office, and I'll show you how. Just some kind of information. A lot of people have asthma. We know that. So it depends on your definition. I've seen numbers up to 300 million worldwide. Somewhere around 8 to 12% of the U.S. population is bothered by asthma. The prevalence is increasing. This is one statistic I saw. It's somewhere between 10 and 50% each year, depending on the year, that asthma is increasing. We're not really sure why. We think that there's some factors like obesity and diet, but nobody really knows, but we're probably going to have this continue to increase. Severe asthma is a problem. Severe asthma is something I'm going to focus on a little bit, more of how you identify, but it's something that we really have to focus on. Everybody in this room, I'm sure, is working on admissions and readmissions, and these are the asthmatics that are in the ER and causing those hospitalizations. I'm not sure what this means, but the annual cost is equal to the value of Facebook. It just sounded neat. All right, so first we got to identify a problem. Part of the problem in treating asthma is that patients don't have big health literacies. They don't have health literacy that helps them help themselves. About 44% of patients in the United States have low to basic health literacy. What's that mean? Well, low means that they can't take a bus schedule and manipulate that and get on the right bus. I mean, that's pretty telling. In our population, in our office, we used a scale called the meter to try and figure out what the health literacy was of our office. The meter is really easy to do. It's a series of 40 terms. They check off the term that's real and leave the terms that aren't real alone. There's many others. We chose the meter because it's quick. They literally can do it in a couple minutes. It's very easy to score. They don't really use it on an individual basis unless somebody's markedly low. But about 8% of our population had a very, very low health literacy, and about 35% had a low to marginal. So I started to think about how do I communicate with patients better so that they understand what I'm saying and take something actionable back. And I'll show you what I developed, but I tried to make it so that all of my patients can understand it, not just the ones with the higher literacies. When we talk about severe asthma, there's kind of two kinds. There's the severe when they're not doing the right things and they're uncontrolled for those reasons, and there's the severe because they are doing the right things, but they're resistant to standard treatments. And we really need to figure out who they are before we're referring them for a biologic. We need patients to know that they're adhering to using that corticosteroid inhaled before you send them for therapies like this. So we'll talk about that a little bit. All right, so I always believed in the patient leaving with something. But when they leave with something, the reality is, and the statistics show, it ends up in the trash can. And that's for lots of reasons. One, it's human nature. Two, because they're too busy. There's too much information. It's not health literate appropriate. Sometimes I have to stare at it and figure out like what I would do, and then I'm expecting the patient to leave there and understand some, detailed action plan. So I started thinking about, well, what would it look like if I made something? And I would take all the ones, and you've seen them with the red, yellow, green, and I would sit and I would pick what I thought was good on it and what I thought was bad on it, and really started making a list. And we want to individualize it. We want to make my interaction with the patient more meaningful, and then eventually we want some outcome to come of it. Less exacerbations, less admissions. I like to get paid by the insurance companies. I want my admissions down. So the things that are in the sheet that I'll show you is I wanted patients to have a better understanding of how to access us, when to go to the ER, when not to go to the ER. Disease state messaging. Across every disease state, handouts typically are just not designed and not in some simple sentence that patients can start with a basic understanding. They're very good, they're very well thought out, but most patients just need something basic that you can build on. I wanted to make what I do, make me teach something in the office and in that visit, and I want them to teach back to me. I want to improve medication adherence. That's really key in many diseases, obviously, but in asthma, it is incredibly key. I wanted to make sure that what I did in that visit, my interaction, was making sure they were getting the appropriate testing and monitoring. And then this is something that myself and my partner, Megan Santana, just constantly talk about, is addressing the barriers. I could sit down with a patient month after month after month and make the best plan. If there's some reason they can't carry it out, we need to help them identify that so that we can help them with it. All right, so this is the sheet. This is not one page. This is two-sided. So the right is actually the front. So we'll start on the right. Now, you don't have to look at this whole thing right now because I'm going to kind of deconstruct it as to how it fits into PCMH ideals and concepts. So actually, I want to show you one thing that doesn't get deconstructed. On the far left, if they smoke, they have to leave the office choosing one of those. Now, it doesn't mean they're going to do it, but we take a time out and we say, what are you going to do to stop smoking? And some people tell me they're not, of course. Okay, the first thing that's front and center is so many asthmatics are using their inhalers wrong. They're treating their exacerbations themselves. They're not doing the right things. They're not calling. They're not coming in. So we wanted to improve that. When you look at the handouts that exist, there's so many different symptoms that they're supposed to take an action on. I just wanted to pick a few that I thought were big. I just want them to concentrate on that. Of course, there's many others, and I wanted them to know what to go appropriately to the ER for. Along with this, though, your patients have to have access to you. Giving them the phone number, making them understand when to come in, you have to give them same-day appointments. This is one of the best things that happened to our practice, is really having appointments for sick visits and really then getting my staff to understand who needs to use those appointments. If an asthmatic calls with symptoms, it's an appointment that needs to be seen. The next thing is transition of care. So we all have talked about that. Everybody's doing it. Everybody's working on it some way. I do my own hospital work, and I'm discharging them, and I'm seeing them at the transition of care visit, sometimes, because we make an emphasis on it, 2, 3, 4, 5 days. And in your asthmatic population, really in all disease states, it's amazing how much is screwed up with that med rec when I discharged them and I saw them 2 days later. You just have to think about that. Med rec is key. The medicine obtaining is key. So do your transitions care as fast as possible. Depending on your ADT feeds that exist, track your emergency room, get them in as fast as possible if it's asthma. If somebody goes for a broken foot and you're just making sure they're seeing ortho, that's one thing. If somebody goes for an asthma exacerbation, take that opportunity to get them in as fast as possible. You may reduce that second ER visit. You may reduce their chance of dying of that. So it's extremely important. Coordination. So this is the wording, which I try to keep very, very, very simple, certainly on disease state. Most patients don't have this ability to learn, detailed things. I have one of these with diabetes, and I think, diabetes, every year we learn another organ's involved. So, I can't expect patients to know that. I just want them to understand something simple and go forward with it. The other thing is, with using a sheet like this, and I encourage you to just design your own of what's important for you. We use it every visit that's around asthma. We use it visit to visit. We use it, my nurse practitioner uses the same language so that each visit they're getting the same message. If they seem to have it down, then we go from there and build on that knowledge. One of the most important things is, too, I think the thing on the top is they do not know how to use these inhalers unless you show them and unless they show you. Make them show you and just make them comfortable when they don't know, because sometimes they're going to fumble around with it and pretend they know, and they don't. Just make them comfortable to show me what you do with this inhaler, and then, obviously there's opportunity to teach them. The middle part is all left blank on purpose. Every visit for an asthma, I sit and I write it with them, and I make them say it back to me. I'll put albuterol in there, I'll put Advair in there, and they leave with this every visit. It may end up in the trash, but the next visit they're going to get the same form. And it's amazing that, when I give them this form And a lot of this is dealt with samples. Probably many of you use samples. It gets screwed up in every visit. Sometimes it's different inhalers. So that becomes extremely difficult. So I want them to leave with a written plan. The last thing is that I think was really eye-opening for us is we stopped asking if patients were taking their medicines, because all of my patients never miss, which was really great. It was really great. It's really great. And then there's reality. So we asked the question, and I try to, make the patient comfortable. I say to them, listen, everybody misses their medicines. I know you miss your medicines. I don't care what it is. Tell me what it is. And then sometimes you'll get something right away, and sometimes you have to prompt them. Is it the second dose? Is it, you're on the run? Is it something that we think about all the time, like cost? A lot of these inhalers are very, very expensive to them. And I think that elicited a response much more often, and it gives me something I can work on with them, and we write down right there what it is, so they can take it home and remember, all right, I'm going to do this. I'm going to put it next to my toothbrush, whatever it is. Hope they brush their teeth. All right, so, and I forgot to mention, you can see, you probably have seen that, like I've outlined kind of, where this relates to PCMH, which each part of these are. So this is really a timeout for the patient, but it's a timeout for me, too, to make sure that I've done the most important things in treatment going forward. All of these patients should be regularly having PFTs to diagnose them and to assess the efficacy of their treatment. So we do it in the office, and that's the first line my next appointment is on. And I am referred to, we also use the hospital to do more detailed testing. The next part, which isn't highlighted in red, is a timeout for me to make sure I am identifying my severe and that they're going beyond standard treatment if they're adhering, and I've identified that. We start making sure that they're getting allergy testing, that I've looked at IgE, that I've looked at the eosinophils, and then I'm making a decision medically off of that. We talked about reviewing the inhaler, and we talked about smoking, and then the vaccines are key. If your asthmatic is getting pneumonia that you could have prevented, that's just something that's on us. So I'm going to wrap up, and then we'll have questions. I think we'll have the questions up there, and if anybody has any questions, feel free to ask. I'll be around for a while if you just want to talk. This slide could go to any talk that I've ever given. It's really important that you pick something that you want to do. It's the patient-centered first. We all know that. Every one of us is in this to treat the patient and do the best for the patient and have the best outcomes. But if it's not meaningful to you, you're not going to do your best job. You're going to do a good job. You're not going to do your best job. So pick the things that are the most meaningful to you and do them. My idea with these sheets is something that I think about all the time. Don't try and do everything. You can't do everything. You can't do every concept every day. Start with one. Start with the ones that are important to you and build from there. Think about your patient's social life. Their social life, every aspect of it impacts their care as much as you've given them a medication, maybe more. So don't forget about health literacy specifically. The patients, I don't know if any of you caught my talk in the morning yesterday, we started interviewing and really trying to understand what patients are taking back from my messages, and it was really eye-opening how much they don't know what I'm saying. The last thing, embrace change and march forward. Everybody thinks Thomas Edison invented the light bulb. He did not. There was two gentlemen that invented it before him, but he invented one that was affordable and would last a lot of hours. He improved the light bulb. He did not invent it. And that's what I want all of you to think of. Like, just go forward and don't try and reinvent the wheel. Just do what's good for you and keep going. That's why you're here. Every one of you is like that, somebody that pushes the envelope. It's really exciting to be with everybody at these kind of conferences. So that's my talk. All right, any questions? And if not, yeah, go ahead. Right. We did it. We gave it to our patients, about 200 of them, and then I accumulated the statistics and then tried to look at that percentage I came up with. We did give it to our staff, and I was happy to find out that everyone got them all right or was on the low end of the proficient. So there was a kind of a wide gap in the proficient, though. So I was. It's called the meter, METER. Someone developed it. Her name is Catherine Ralston of Kent State. If you Google it, it will come up. Yeah. And I found that it was quick. You know, we have so many handouts of forms that we give to patients, and like one more that would take 15 minutes would just, their minds would explode, you know. So it was just something we could do quickly and kind of see where we were. Thank you.
Mm-hmm. Go ahead, man.
Do either of you have experience in or knowledge of the effect of vaping or medical marijuana on asthma?
Marijuana and asthma? Well,
Marijuana.
I guess that's a really good question. I mean, I think because of the various impurities, not just of the cannabinoid itself, but the various other toxins and excipients that are in there, it's very, very difficult to tell because depending on the state that sells it, there's all these different brands that you can buy. And I don't think any of those excipients are regulated in there. At the end of the day, it's a toxin just like anything else. So I don't know if there's been any type of long-term assessment of marijuana or cannabinoid use in asthma patients specifically. But I mean, just like anything, it's an irritant. It's going to cause bronchospasm. It's going to exacerbate the problem. You don't have to directly inhale. You can be a secondary person in the area being exposed to it. So I don't know specific data on cannabinoid impact on asthma from a sociological perspective, but I think it's something that people are looking at.
Thank you.
Yeah, sure. Yes, ma'am.
Hi, it's really exciting to hear about all the advances in medicine and the opportunities to treat asthma. I'm the Vice President of Quality for an FQHC. About 35 to 40% of our patients have no insurance. So while, on a one-on-one basis, some patients with more severe asthma may be able to take advantage of these, is there anything being done to systematically reduce the cost of controller medications? Our patients just find it's cheaper to use their rescue inhalers than to go on the controllers. And so we've done a lot of work over the last 2 years, and the main factor in noncompliance is the cost.
I have to agree. I mean, the patients that I work with in the spirometry clinic, 250 patients I've seen. When you're dealing with inhalers over $200 easy for each one, it is the number one issue that we've experienced, that is the non-compliance issue, without a doubt. Some of the companies have some type of promotions where they do certain things, but again, they're very inconsistent. And I don't know if a lot is being done to lasso that cost in. As you know, we look at these biological therapies and stuff, you're talking tens of thousands of dollars a year. And it's getting out of control. And as we've seen in the past, various other pharmaceutical companies, what they've done to raise prices, ethically, I think that's an issue. But I don't think anybody has really addressed the major issue, the cost. I mean, we've tried with the $4 generics, you do all that kind of stuff with a chain store or stuff like that, that a chain may offer that. But there's very limited opportunities. Mike, anything you know?
So the programs from pharma, like are really good. The problem is I would have a hard time filling out the form. So we're dealing with patients and families that don't have the abilities to get into that program. Now, I don't know what you do at your office. We've at times helped them with it, but I don't have the resources. That somebody would, if we did every one that we thought was something we should do, which is a lot, I'd have somebody full-time all the time just filling out forms, and it's just the resources aren't there, so you're left to the families that can do it. What we try and do now is lean on really finding a family member and telling them about it and getting them to do it, or some of our insurers have really invested in care managers, so we have them try to help them, but it's really difficult.
So there's nothing on the horizon that we can expect the cost of controller medications might become more. Okay, thank you.
Yeah.
Other than the competition with so many new ones, that may drive some, but they're still going to be very high cost. All right. All right. Thank you.
All right, everybody. Thank you so much.